Dear doctors, welcome to the Atlantis Scleral Lens webinar. Good evening to all of you. Assalamu alaikum, marhaba. I hope that everyone is well. With me, I have a great friend, Tony Caporali. He's one of the ones. He's one of the main key opinion leaders that developed Atlantis over what, Tony, 15 years ago?
Yeah, I think we're approaching 15th year. Yeah. So it's
Nice.
amazing. Yeah, you had a big part in that too. Don't be shy.
No, it was all you, my friend. It was all. Well, welcome to this webinar. I'm very pleased and glad that you're all joining. We have people from all over the MEA region, the Middle East and African region. And like I said, we have a great friend, developer, consultant, and speaker for Atlantis. So please, if you want to ask questions, raise your hand. You can also do the chat, or you can put the questions in the Q&A. If you want to share any cases, if you want to discuss any patients, please, this meeting is for you. So please feel free to do so. Okay. Tony, it's all you, my friend.
Okay, thank you so much. Yes, please. Questions are always welcome. If you have individual cases, I always like to address those because it'll teach us different things and different ways to talk about the lens. So we appreciate your time. We know that's very valuable. So we will try to provide you the value that you need. Again, Felipe mentioned it. I'm Tony Caporelli with XL Specialty Contacts. I've been in the contact lens industry for 32 years now. So I'm the director of product management. I'll talk about a little bit of what I do and how it works. Just a little bit about XL. We're based in Atlanta, Georgia. We're doing almost 2,000 RGPs a day. And we have an advanced robotic system that really helps with the turnaround time, which is very important with most of these highly irregular corneas we're dealing with. We're providing lenses for these irregular corneas. And a lot of times these patients need the lenses very quickly. So that robotic system helps with the turnaround time, also with reproducibility. You can be certain that if you order a lens today and you get that lens and you need to reorder that exact same lens, those robotic modules can produce the exact same lens. So it's kind of taken some of the human interaction out of the manufacturing process. And XL and Essilor Contacts does everything in specialty lenses, including a couple scleral designs, Ortho-K, many corneal GP lens designs that have been out for many years. And then we also have irregular soft lenses, irregular cornea soft lenses, which can be utilized when a patient doesn't want to go into a scleral lens or they think there's more of a convenience with the soft lens. So just some things to think about when you're thinking about the products that you can provide. As Felipe mentioned, our design has been out for 14 to 15 years. It really started to boom with scleral lenses around that time. We thought we were kind of late to the scleral lens game, but now when we look back and how sclerals have grown, I think you probably know, and we know here in the United States, that it's just a problem solver. We can take any of those irregular corneas and really solve some of those problems we had with corneal gas perms and utilize a scleral lens to solve those problems. So this is one of the first cases we actually had, a fitting I did in New York. This is a classic example of changing lives with scleral lenses. I apologize for the black and white topography, but they had to make a copy for me. Upstate New York, an older practitioner that had never fit a scleral. This is her first scleral patient. And just a quick case study. You can see bilateral corneal transplant, only using a right lens. Actually drove to the appointment, but was very scared. It was a 15-minute drive, but was very nervous and scared because of her lens popping out several times during the day wearing that corneal GP in the right lens. Nothing in the left lens, ptosis from the surgeries. And this is a patient that this doctor came to me and said, well, if you are going to tell me that sclerals are the greatest thing, well, then you should be able to fit this patient. And again, we did. We had a very successful fit straight from our trial lens. We ended up in a larger diameter. We'll talk about how a highly irregular cornea will utilize a larger diameter a lot of times, which may be different than the standard diameter we start with. But this is just changing lives. No lens awareness, literally cried in the chair, wanted to keep the trial lens, even though we had a large over refraction, because it was still better than she was seeing. And then the difference between the top picture and the bottom picture are no lenses in the top picture, lenses in the bottom picture. That ptosis had kind of opened her up, and look at, she was so happy. She said she looked younger just because her eyes were more open. So if you haven't fit sclerals, it's a life changer for some of these patients. If you have, you already know this. So we'll talk about our design specifically. If you've used other designs, I think there's some differences between every design, and there's some similarities between each of these designs. When we went to market years ago, we wanted to really keep things simple. So we keep it in 3 simple zones. We'll talk about those zones. We'll talk about the fitting of that and how you can manipulate the lens. And we want to keep it simple, even though most of the time we're dealing with highly irregular corneas and these specialty lens patients, we can still keep the fitting process simple over that irregular cornea. So keep it simple. Think about it in simplistic forms and the manipulation of those zones and how much we manipulate that. We all need to be on the same page of what our goals are with a scleral lens. We want to vault the entire cornea, as we know, and land outside the limbal area, right? We want to make sure we're outside the limbus, so we need a large enough diameter to do that, and also have enough sag or vault in the lens to clear that irregular cornea if it is an irregular patient. When we're looking at the advantages of a scleral, again, if you have not fit these, there's so many advantages when you compare it to a corneal GP. And I just love talking about this because you may or may not know all of these. They're extremely comfortable when they're well fit. So that's a nice little pearl, is I know when I have a patient that's comfortable, because throughout the fitting process, we will consistently ask them, how do the lenses feel? If they're extremely comfortable, I know I've got a pretty close fit. Part of that comfort is that no lid to edge interaction. So it's a nice thing that you're not having that lid bumping up against the edge of that lens. These lenses will center well most of the time. They are big, heavy lenses, so the tendency is to decenter inferior temporal, but they're still a large enough lens that we can get that over our visual field. So they center pretty well. We'll talk about how we can help with that centering process with that edge dynamic. Of course, we're hydrating the cornea. So if you think about drier eye patients, you guys, most of you are in a drier area, so you probably have problems with these patients. And what lenses can I utilize with the atmosphere or the climate that you're involved with? We know that these lenses do not move once they settle. There's not movement, so there's no possibility of these lenses falling out or losing the lenses. And then one thing that is kind of overlooked is the adaptation period. With these lenses, a lot of patients can use them that first day for 12 to 16 hours. So they can get a full day of wearing time as soon as we dispense the lenses. Not all practitioners will want them to do that, but with corneal lenses, if you compare, we used to go through a process with corneal lenses where a patient would wear the lens for 2 hours the first day, and 4 hours the second day, and 6 hours the third day, and so on and so on. And after 2 or 3 weeks, then they had a full wearing day, where with scleral lenses, again, they can go straight out of the gates 12 to 16 hours and wear that lens all day. We started out with sclerals fitting mostly irregular corneas. There aren't too many corneas we've seen that we can't fit with a scleral. But if you are going to fit sclerals, you should think about the other patients. We're fitting a lot of normal corneas now, including ocular surface diseases, dry eyes, patients that have normal corneas, but still may have an advantage with a scleral. A lot of multifocal patients are now being fit. Again, because we can have that hydration behind the lens. We know that older patients tend to be drier. Athletes. So if you're going to get in and you're going to invest your time and your money to fit sclerals, try to think about that patient base and opening that up. Okay? Also, you want to prepare yourselves. So if you are fitting sclerals, I'm sure you've already done this, but you'll need a fitting set. which we're going to talk about how our fitting set works and how you can take advantage of that and reduce your fits. Having some of the supplies, the removal and insertion DMVs. Also, you want to have preservative-free saline, and many of the companies, and Felipe's company, can provide these salines, and they may also provide other nutrients through that saline, but it has to be unpreserved for the patient. And then cleaners, you're going to need a lot of fluorescein strips, things like this, where you really want to, if you want to build the infrastructure before you start fitting patients, you want to have these in the office so you can get going and provide the patients the best experience. So let's get into our design. Again, I'm going to key on simplicity, but I don't want you to think that it's so simplistic that you don't have a lot of manipulation within the lens design. When we look at our fitting set, these are our fitting set diameters. We also have diameters outside of this range. We go from a 14.0 diameter up to a 17.5 diameter, but within the fitting set, we have 3 diameters. So we do X marks the spot, or the starting lens that we say, or we want you to start with. We have a smaller lens or a compact lens, which is a 14.5. And this is for those small fissures, Asian patients, any patients that are having problems with insertion removal. You may want to start with a smaller diameter. And that's really one of the main reasons we start with a 15.5. Some practitioners want to start with a larger diameter. I told you that we want to vault the limbo area and land outside that limbo area. Well, I would just use a larger lens to do that. But one of the main reasons patients will not go into scleral lenses is because of application removal. If I can keep my diameter smaller, that is an easier lens to apply and remove. So that's why we start with that. Also, we had, I don't know if you saw the slide, but we have about 700,000 lenses on eye. We take that clinical history and all of that lens data and start to evaluate that historical data and what works the most times. So of those 700,000 lenses on eye, if we start with a 15.5 diameter, it's fitting about 95% of the corneas that we see. So again, I can keep my lens smaller and fit the majority of the lenses. Then we have our large diameter, which is a 16.5. And truly, you only need a large diameter when you need more sag in the lens. Larger lens, more sag. So if I get to the end of my rope in the fitting set in my 15.5 diameter, I have the option for a deeper sag with a 16.5, and we'll look at that lens. We'll look at that fitting set. Okay. We keep this set simple as it could be. It's going to come in a nice case inside a vial. On top of the vial is going to be a vial cap label that gives you all the pertinent information. We'll give you a lens identification mark. So if you mix up any of the lenses, this identification mark is going to be lasered into the lens. You can also use this for your record keeping or when you're talking to consultants. Most of our fitters in the United States will use this identification mark with the consultants. They will simply say, I had on lens X4A. Here's what I saw centrally. Here's what I saw limbal. Here's what I saw edge. This is my over refraction. Make me a new lens. So again, for identification of the lenses in case they're mixed up in the set, and then also for record keeping. We only work in sag now, even though on the side of the label or the side of the vial, you will have your base curve. We work with sag. So base curve is really taken out millimeters, diopters. We're only worried about the depth of that lens or the sag of the lens, and then that relationship to the cornea or our clearance. So that's really what we're working with, the sag of that lens and how we're going to manipulate that up or down. Of course, diameter is important. And then we put on there what our edge makeup is. And the edge is where most of the changes are made on scleral lenses, because that settling process and it's unpredictable. We're making most of those changes on the edge. We're going to talk about every zone within the lens and how that works. Important to note that all lenses are -3 power, so it makes it simple for your over refraction to know that I need to add in that -3 to my over refraction. And then all the fit set lenses are 300 microns thick. We know that we're going to take a measurement. If we're doing that with the slit lamp, it's important to know the thickness of the lens. Okay. Now we're looking at the set. We color code each of the diameters, again, making it simple. We said 15.5 is where most of the patients are fit. We give you a starting lens. We put 2 lenses in each of the sags because most of the time we're fitting binocular. So you can see that the lenses in the starting lens, and this is just a starting lens suggestion. This doesn't mean you have to start with this sag. You can start wherever you like. If you want to start with a larger diameter, not an issue. But we chose this sag because it is the most utilized sag, or near the most utilized sag of all of that clinical data we have. So that's why we choose that starting lens. But you see there's 2 lenses in each of the sags. The only difference between those 2 lenses is the edge. And we're going to get into that and how that edge works. But it's the same sag, same diameter, just a different edge. All right. Important to note, between each of the lenses in the 15.5, there's 200 microns difference. So when I'm manipulating within the set what lens I'm using, there's going to be a 200 micron difference between them. And again, we have a smaller diameter with lower sags and a larger diameter with deepest sags. I alluded to earlier, if I run out of room or if I have a cornea that's highly irregular, it could be a corneal graft, PMD, a central nipple cone. These types of patients usually end up in a larger diameter. So I have that option and those deeper sags within the set. Okay. I'll give that as a stopping point to address any questions up until this point. We're going to get into the lens zones and how they're manipulated and how we make sure that we're moving the right pieces of the lens when we have these different patients. Questions? Are there any questions in the chat?
No, T, you can go ahead. No question.
Sounds good. All right. We talked about the lens identification mark. That's always going to be lasered in over your quadrant. With this design, we have quadrant control. So we break that lens into 4 different quadrants, and we can control that in our limbal zone and our edge. These are only the laser marks on the fit set lenses. I will talk about the patient lenses. So it's very simply 1 dot for quadrant 1, 2 dots for quadrant 2, and so on. These dots will not always align like they are now. We will not always see dot 1 at 3 o'clock. Dot 1 may be at 5 o'clock. It may be at 7 o'clock. So it's important to note when you are fitting the patient and you're evaluating the fit from the fit set lenses, note where the dots are. So I'd simply say dot 1 is at 7 o'clock. And then I know where the rest of that dot pattern is. But make sure you note where your dots are aligned, especially if you're making a change. The consultants need to know that. But this is only on the fit set lenses. And then you have your identification mark above quadrant 1. When we look at the design, the best way to fit this and the way we want you to look at it is from the inside out. And there's a few reasons for that. We want to get our central zone first. If I have touch or bearing, right? In this case, upper left-hand corner, we have bearing, or in this middle fluorescein pattern, we have slight touch. If I have touch or bearing, there's no reason to evaluate that lens. I have to put on a deeper sag and then evaluate it. So I want to get my central clearance first. So we work from the inside out. The other reason we do that is I told you that most of the changes made on sclerals are made on the edge, or what we call the scleral zone. We want to give that lens as much time to settle before we evaluate that edge. Studies have shown that the settling process can take 4 to 6 hours. So for a lens, a scleral lens, to fully settle on a patient's eye, it can take 4 to 6 hours. But about half of that settling process, right? Half of that process can happen in the first 20 to 30 minutes. So if we're fitting the patient and we do the central zone first, and we do the limbal zone, and then we can do our over refraction, then we can do the scleral zone last, and then we've had that lens on for a period of time that's probably in that 20 to 30-minute range. So inside out, central zone first, limbal zone, and scleral zone is the very last thing we want to evaluate. Okay. Looking at our central zone, what are our clearance goals? And I think this is mainly every design is between 200 and 400 microns. So we want at least 200 microns of clearance over the apex or the highest point of that cornea. All right. And this can be evaluated upon insertion. We know if we have at least 200 microns of clearance, even after that lens settles, we should still have clearance over the apex of that cornea. I get a lot of questions on how much is too much clearance, and this can vary. I know if you stay within 200 to 400 microns, you're going to be good, and we call that the wheelhouse, right? Too much clearance can be over that 400 microns, but there are situations where I could have more than 400 microns of clearance and the lens fit still be okay. When you have too much clearance, you may distort your optics. You may get a bad over refraction or chasing your tail with an over refraction because of that clearance level. If I cannot get a good endpoint on my over refraction, it could be from too much central clearance. We also you've probably heard about fogging or haziness or buildup behind the lens. Well, this can also be caused from too much clearance. All right, so look at that central clearance, keep it between 200 and 400 microns. Know that every scleral lens is going to settle, so we're going to lose some of that clearance. And studies show it's about half of what you start with. Okay? When we're measuring that vault, you've probably seen this before. We're taking that slit lamp at a 45-degree angle. I like to use a white light so we can pick up the front surface of that lens. And it's a simple evaluation of our lens thickness, right? We see the reflection off the front side of that lens, our clearance or our fluorescein, and then our cornea. You can measure that fluorescein or compare it to the cornea. I like to do it to the lens because, as I alluded to earlier, I know the thickness of that lens and it's 300 microns thick. I also want to make sure that I'm looking at the apex of the cornea. We say that, we can take that measurement centrally, but here you see that superiorly, we have a thinner band, which means less clearance. And inferiorly, we have a thicker band. Irregular corneas, you're going to see differences in your band or your clearance heights accordingly. Okay. If you're having any trouble picking up that reflection off the front surface, just wipe some fluorescein on there and it'll illuminate really easily. So how does our central zone work? It works in 25 micron steps. That is increasing clearance or decreasing clearance. And we can manipulate just that central area, 300 microns total. Okay, so again, up or down, increase or decrease our central clearance only. It's an independent zone. So if I increase my central clearance through a central sag adjustment, it's only going to affect that center area and our sag in that central area. It won't affect my limbal area or my edge. It's an independent zone. It's not done through a base curve change. It's actually done through the junctions. So what I mean by that is where the central zone meets the limbal zone, that's a junction. We manipulate the sag, the central sag at that junction to increase or decrease our overall sag or our clearance in that junction centrally. Our limbal zone will stay the same and our edge will stay the same. So if we go back and think about the fitting set and how that works, if I put on lens X4A and I had 500 microns of clearance centrally, and I wanted to reduce that, I don't have to necessarily put on my next lower sag lens in the fitting set. which is 200 microns less. So if we started with 500 microns, if I went from lens X4A and put on lens X3A, I should expect about 300 microns of clearance in lens X3A, right? Going from 500 down 200. But I do not have to put that lens on because I can simply do a central sag adjustment. I can tell the consultant or order 200 microns less centrally, and that does not change the base curve. So if I've done an over refraction, that won't change the over refraction. All right, so up or down, every step is 25 microns. So I can add one step, 25 microns, two steps, 50 microns, and so on. Also, I can take it away, but every step you do is going to be 25 microns. It makes it very simple working in whole numbers. Okay, this is just a simple illustration of the difference within the set of 200 microns difference. You can see we have a very thin band, not enough clearance, adequate clearance here. And if we go back to our OCT image, that is the lens where we have 375 microns centrally. Felipe talked about Medmont and the scleral topographer. You're going to have these wide views where we're getting all of the lens, and we can get that information that's way outside where that lens is landing. We used to not be able to do that, of course, with the corneal topographer, but now we can really decrease our number of fits if we can get that information and what's happening out there where that lens is going to land. Okay. So that's just the difference between the set lenses and the 200 microns. And you can see increasing that, how our clearance increases. Within our set, we have a fitting guide. All of this information we're going through is in the fitting guide, but also we have a decision tree. And this really keeps everyone talking the same language. Our consultants utilize this, and we would encourage you to utilize this when you're fitting the lens. You can simply see your evaluation and then make the change. And then that change is what all the consultants would change to based on what the evaluation is. So another good stopping point, we're through the central zone. I think sometimes it can be confusing on what a sag adjustment is and why it's not a base curve change. But it is an independent zone, moving it up or down within that junction instead of using a base curve change. Because most designs, including ours, if I change the actual base curve, I change the entire makeup of the lens. So I'm sure some of you have dealt with older designs like a Jupiter, and those were counterintuitive. Again, if I change my base curve, if I flatten my base curve, it would flatten our edge. Well, now when we have independent zones, I can manipulate those zones independently and not worry about affecting the other parts of the lens. Questions?
Yes, T, there's a question.
Mm-hmm.
Dr. Subo Madanat from Oman is asking us, for the quadrants, we have to specify where the dots land and tell the consultant. Do we need to mention this in the order form? That is, if we want to manipulate the quadrant depending on the patient landing zone?
Correct. So, and I would do that in all cases, even if we're not going to make a change within a quadrant. I would still note where the dotting is on as a clock hour. So again, if I saw dot 1 at 7 o'clock and I want to make a change, the consultant will know that dot 1's at 7. Also, this is valuable if we need to make a front toric lens. So if we had some residual cylinder coming through on our over refraction, we need to know how much rotation we've had in that lens so we can offset the axis when we use that cylinder in the over refraction. Why does a change in the scleral zone affect the sag? Hi, Dr. Naji. Okay. With the independent zones, we will not affect our central zone clearance. So I know Dr. Naji is familiar with the first generation fit set and how our lens manipulation was different than it is now. But now with these independent zones, the scleral zone change will not affect the central zone. Does that answer both of those questions? I saw Dr. Najee's pop up.
Yep. To
Okay.
me, you answered them, but are there any other questions, Dr. Najee or Dr. Subo, on the dot or the scleral zone affecting the sag? Is that all clear? Clear. Okay.
Great. Thank you.
Perfect.
All right, let's move to the next zone. So our limbal zone. And I know
Tony,
that
I do have a question.
Sure.
Sometimes some of our doctors try to increase sagittal height by steepening the base curve.
Mhm.
If they steepen the base curve, they have to do the SAM flap rule, right? For the
Correct.
overrefraction.
Correct, because you're actually changing the base curve.
Okay.
So, and I think there's some confusion there on how to manipulate that. Again, we can make a central sag adjustment, so decreasing or increasing the sag without making a base curve change, and that's the way the consultants should guide you instead of making a base curve change, because you said if I steepen the base curve, so yes, if I steepen the lens, what am I going to do, Sam and Fap? Well, then I have to do my plus. Steeper add minus. If I change the base curve steeper, I'm going to steepen my edge also. If I do it through a sag adjustment, right? So let's just say I wanted to increase my central zone 50 microns. I could change my base curve a half a diopter steeper to increase that sag, but then I would be steepening my edge, and I would also have to incorporate that into the overrefraction. If I want to add 50 microns to the central zone through a sag adjustment, not a base curve change, I can simply say, add 2 steps, 25 microns each step. It's not going to affect the edge, and it's not going to affect the overrefraction. Is that clear? I know it's confusing, but it's 2 different ways to change your sag, but make sure it's known that a base curve change changes the entire design. A sag adjustment just does that zone, not the rest of the lens.
Yeah, so it's very important, doctors. If you do change the base curve and you steepen it, please remember the SAM flap rule. Steep add minus, flat add plus. So whatever diopters you're doing, you have to do it in the overrefraction as well, in the final power as well.
On a base curve change, yep.
On the base curve change, not on the sagittal height change, like
Correct.
Tony was discussing.
Yep.
Dr. Naji says, listen, I mainly fit Atlantis 2.0, and I think I saw that changing the SZ will change the sag.
Again, they're independent. So what we've done is it will, so I shouldn't say it does not change it at all, but it is offset to make it an unnoticeable change. So yes, if I flattened my edge 360 degrees, or my scleral zone, all the way around, and I did it 8 steps, which is 200 microns, it will have a nominal, which means not even visible, change through your central sag. But we've offset it to make it that it does not affect that clearance enough to be a significant change. Yes, if I was changing one part of my scleral zone all the way 360 degrees, it could have a slight effect on the central zone. But all of these are toric edges, right? So we have that toricity where it aligns better. And when you're making changes, we'll talk about it, but in a quadrant specific manner, or even in a meridian manner, it will not affect that central zone. You'd have to make significant changes in a 360 degree manner. So Dr. Naji, we've talked about it. So what it comes down to is getting that best edge from the fit set when it's that you're making the change you're going to make. If you need to make a change on the edge, it's going to be a very slight change. You may change it 50 microns at the most because you've done your due diligence on the fitting set lens or the trial lens. I hope that doesn't confuse. We'll get into that too. We'll talk about it, and then if we have more questions or if we want to get more in depth, we can do that. Okay.
Yeah, Dr. Abdullah from Saudi Arabia is asking us, how does a change in sagittal height not affect the power?
Because it's not a base curve change. So we're keeping that same smooth base curve. Again, if we had, so say we had a 750 base curve on the lens, and if so, we're looking at this area. So I will do this. Here's your base curve, right? How we make this lens, how we can manipulate that sag is through that base curve. So if we flatten it, obviously we'd have a lower sag. If we steepened it, deeper. But when we're doing a central sag adjustment, right here is where the junction is. So it's a manipulation at that junction that pulls that lens down or pushes it up. Okay. So this area stays the same. That base curve does not change. But in this junction, if you can see, it's just like this, where this junction is, it's taking that lens and going or up, but we're not changing that base curve. You have to think about this. It's only microns of difference, right? It's microns of difference. And we're doing that through that junction instead of a base curve.
Got it. So I also have a comment from Jesse Espiritu, which is our distributor in Saudi Arabia. And he says, your scleral lenses are highly regarded among the most prescribed in our region. The quality of your products is well recognized and is trusted tool for many practitioners. To build on this success, I believe there's a significant opportunity to strengthen your presence through in-person educational activities. While virtual events are valuable, direct hands-on participation is crucial for keeping practitioners updated on the latest fitting techniques and fostering continued confidence in your brand. Uh, Considering this, the Saudi Conference of Optometry, November 6th through the 8th. Jesse, I don't know if you remember, but I spoke with your boss, Mr. Haytham Algari, and I talked to him. I think it was back in May and June, and I told him that I would be willing to participate in the Saudi Conference of Optometry with a speaker and a fitter, that we could do roundtables, we can do feeding experiences for patients and doctors, we can do hands-on training. I never heard back from Al Musabi Kalarabi. So for future reference, yes, we are willing to go to each individual country, Oman, Palestine, Saudi Arabia, Lebanon, and we can do hands-on training, we can do workshops, we can do all kinds of activities. Unfortunately, Dr. Jesse, November is next month, so it will be extremely hard for us to travel to the Saudi optometry conference. Also, based on the information I've received from Mr. Haytham, your direct boss, he told me you will not be participating with a stand. So please, let's just plan it better, and we are willing to help you with all the education support that you need.
And I agree 1000%. And if you don't mind, I just jump in. When we do in-person fittings as compared to a webinar or training like this, and a lot of times we'll do both. So we'll do an initial training like this and then do the in-person. It decreases the exchange rate by about 10%. So that hands-on situation is always better. Sometimes it's not, we're not able to coordinate that for different reasons, but it significantly reduces the exchange. So, and a lot of times what we'll do is, if we cannot do it live, even having the patients in the chair and just going through that and having those hands-on questions can help. So having a consultant live and going through that patient and going through the fit process can help.
Yeah, and we're willing to do that. And just let us know ahead of time, not 30 days in advance, but let us know and we can do it. We have key opinion leaders in the region. They're all fitters, and we can bring them to Saudi, Lebanon, Oman, any given country. Just let us know and let's plan ahead. Let's do it for 2026. I'm more than welcome to join you in this effort. And Jesse, please tell your direct boss, Mr. Haytham, to contact me. I'm attending Saudi Arabia conferences 2 or 3 times per year, so I will be delighted to be with you during these events. Go ahead, Tony.
Great. Okay. So we'll keep addressing questions. I love this. This is great, good interaction, and this really helps. So let's move on to the limbal zone. Again, it's an independent zone. Going back, looking at the fit set, looking through the clinical data, some sets want to have an oblate and a prolate set. So if you do have those post-LASIK patients or post-RK patients, you have an entirely separate set. But through the manipulation of our zones, we can create those designs without actually having a whole new set. We know that when we have those post-LASIK or post-RK patients, we have that flat central area and then that steeper paracentral or mid-peripheral area, which gets into that limbal zone a lot of times. We know that we have to get our clearance over that steeper area out into the periphery of the lens, or the periphery of the cornea, without getting too much central clearance. So in essence, what we can do is create a reverse geometry design through the design manipulation. Just like I think we're well aware of what our goals are. We want roughly 50 microns. Some practitioners prefer a little bit more in the limbal zone, some a little bit less. This can be dependent on the patient condition. Sometimes when we're looking at a corneal surface disease or dry eye patient, something along those lines, we would want a larger lens with a little more room there. We have also seen that too much limbal clearance can cause some of that fogging or haziness or that buildup behind the lens. So it's one of those tricky situations. For me, if I can see the fluorescein getting out past the limbal area to the inside of that edge, I know that I have some clearance for that. So that zone, it is very important. But what we can essentially do is just control that area. If we see that touch or bearing in that area, this is one of my favorite pictures. So if you can see this area right at the limbal section, those are tiny bubbles. When we first started with the lens design and we were trying to prove if we made just a limbal change that it was actually happening. We had a patient that put a lens on and the lens design was the same as the next lens we were going to put on, except we wanted to increase the limbal zone. Well, we told the patient to take off the lens and we were going to put a new lens on, and we put the lens on or we had the patient put the lens on, but the patient never took out the first lens. So this shows that just increasing that limbal zone, we could get bubbles under there because it was the same lens except for a steeper limbal zone. So it proved that our lens design was working, but the patient had two lenses on, not the way we wanted to do that. This gives you a view of how independent we move that limbal zone. So if we were increasing that limbal zone and it just increases that area that we want to, we do that independently. It works just like the central zone in the fact that it's 25 microns every step. The cool thing about the limbal zone is it is quadrant specific. So sometimes I've had that classic inferior keratoconic patient where we may see some of that, the peak or the apex of that cone getting out into that limbal area. And I've got good clearance over that, right? The steepest part. But up here in the superior quadrant, you've probably seen this if you've done some cone patients, we may have 500, 600, 700 microns of clearance. Well, if I really want to manipulate just that zone down, I can do it in a quadrant specific manner. So just like the edge works in most designs, we can do it in a meridian, right? If we wanted to do it in our 180 or our 90, we can do that change. If we wanted to do it 360, again, if we want to make that oblate design, keep our central zone flat, increase our limbal zone over that mid periphery, we can do that. Or if I just wanted to do one of the quadrants, I can do that. All right. We can do that 300 microns up or 300 microns down, 25 micron steps, independent. It won't affect our central zone and it won't affect our limbal zone. All right. And then another thing we won't get into too deeply is not only can we control the height of that limbal zone, we can control where the height or the steepest part of that limbal zone is. So this is just a depiction of this blue ring is where the standard limbal zone peak or highest point of that limbal zone is, because our limbal zone is made up of two curves that intersect. So the peak is noted by that blue area. If I wanted to move the highest point of the limbal zone in towards the optic zone, I can do that. So if we think about a post-LASIK patient and we have sometimes 6 to 8 millimeters of treatment area or flat blue area on the topography, then we have that gradual steepening area. That may be at 9 or 10 millimeters where we really need the peak of that limbal area to be. So you can move that peak in if need be, or out towards the edge. Sometimes if we see a PMD or a graft patient, we really need the peak of that limbal zone or the highest point to be out towards the edge. It's not utilized a lot, but it still is an option. Again, the decision tree where we look at the evaluation and then we're all making the same change and it gives you the output from consultation. All right. Scleral zone is the last zone. I told you how important it is. Most of your changes come on the scleral zone. It's the number one change made with sclerals because every lens settles and that settling process is unpredictable. Most of the time, what are we trying to do with the edge? We're trying to loosen it up because it has settled too much. We used to think that the scleral area just at the limbus or even outside it was pretty spherical. But now with these scleral topographers, if you have seen the eaglet or the SMAP and now the Medmont, we're getting that information. And through some of these studies, I'm sure you all heard of Pat Caroline. He did one of the first studies to say, wow, hold on a second. Even at a smaller millimeter chord, we do have toricity within that area. So we need to make these lenses toric, right, to align better with that cornea or that sclera. So even at a 15 millimeter or 14 millimeter chord, we're seeing toricity. So what we did is started to make every lens with toricity on the haptic or the sclera and that scleral zone. As we looked at these lenses and started to evaluate them, we saw improved comfort. I know that I said a lens is very comfortable if it's well fit. Well, we even saw improvement over that when we made a toric edge. Centration. If you've ever had a decentered lens and you're getting a cylindrical over-refraction, it could be because of that decentration. We've actually created that astigmatism. It's a false astigmatism. So if you've had trouble with making a front surface toric that keeps moving around because you thought you had some internal astigmatism, it could have been from the decentration. So if we have a toric haptic, we can center that lens better, or it helps to center that lens better. So we're not making as many front surface torics. We do get that fogging, reduced tear layer fogging, because with a toric edge, we can actually see some exchange. If you've ever seen some of these posters that show a lens that's first put in with fluorescein, and then in 2-hour intervals, even after 8 hours, there's still fluorescein behind the lens. Well, when we've put a toric edge on, you can see some of that exchange, and it literally is getting some tear pump through there, which is great. And then with that alignment, it's reduced flexure. If you've had problems with flexure, which is very rare, just aligning it better helps reduce that flexure also. So let's look at the fitting set. And let's go back to the toricity and what our philosophy is. I told you that we put 2 lenses in each of the sags within the fitting set. So we're going to look at this 4400 lens in our fitting set and why we have 2 different lenses, or how the makeup of the edges. We told you the sag's the same, the diameter is the same, the power is the same, the center thickness is the same. It's just 2 different edges. And here's how it works. We took a standard edge and we went 3 steps flatter in one meridian and 3 steps steeper in the other meridian. And each of those steps is 25 microns. So 75 microns flat, 75 microns steep, which gives you 150 microns of toricity, right? The other lens in the set, or in the sag, pardon me, is the same amount of toricity, 150 microns. We've just done it in a different manner. We've done 5 steps flat, 125 microns, 1 step steep, 25 microns. It's still 150 microns of toricity, but just in a different makeup, still the same sag. So if you look at our fitting set, the philosophy kind of goes like this. When we looked at the 15.5, why we chose 150 microns of toricity was about the average at that millimeter cord. But as I increase or decrease the diameter, it's about 100 microns more or less of toricity. So if you look at the 14.5, right, we're closer to the limbo area. We have less toricity there. We know as we get further away from the limbo area, there's more toricity. So the 16.5 has 250 microns. And again, I can manipulate this accordingly. I can increase it in one meridian. I can increase it in all 4 quadrants or quadrant specific. The dotting system for the patients is a little different. We do 3 dots, and that's just showing you quadrants 2, 3, and 4. Again, important to note where you are seeing those dots. If you can pick up quadrant 3 and see, directly across that there's no dot, that's quadrant 3. With the scleral lens, we have to give it time to settle. We talked about that process. Half the process can happen in the first 20 to 30 minutes, and then it can take 4 to 6 hours for the rest of that settling process. We want to see alignment. We know all of this. We want to check 360 degrees, eliminate the lids. If I've had the lens on for 20 or 30 minutes and I see blanching, disruption of the vessels at the edge, it's time to make a change, even though that lens has only been on for that short amount of time, because what's going to happen is it's going to get worse. That lens is only going to settle more. With our design, one of the things that we see a lot is edge lift when we first put the lens on. So I don't know if Najee could speak to this, or because I told you that most changes come on the edge, and most of the time we're flattening the edge. So when we were designing the Atlantis, we made our edge significantly flatter than any other design because of those changes that were happening. So when you first put on the lens, you may actually see the edges lifting off. And the patient may be aware of this. They may feel that that lens has some discomfort or awareness superiorly or inferiorly, where the lids are actually interacting with that edge. But as that lens settles, that edge lift will dissipate. So just be known that you don't have to jump to an edge change just because there is some edge lift and some awareness. Once that lens settles, most of the time, that edge lift is gone. So it's kind of nice to have that. This conj prolapse, this is kind of a great subject, and it's always a debate. And it's great to talk about because, these are conditions that are very hard to try to get a perfect fit with. You may even have a perfect fit, but you still have some problems with this conj prolapse. And really, there's not one change that solves this problem. And it works just like any other changes. When we're going to make a change to a lens, be it a corneal lens or a scleral lens, the first change is always what solves the problem the most of the time. But we always give you 2 or 3 options. And that's one of the things with conj prolapse is we really have to look at it and say, let's try this. Did that help? Let's lower our limbal area to push some of that tissue back out if it's sucking back under. If we're seeing some of that edge or that tissue up around over the outside edge, well, then we may have to flatten that to relieve some of that deep diving edge. So it's one of those search and destroy kind of situations. Scleral zone, just like the central zone and the limbal zone, 25 micron steps. This is a little more confined on our abilities. If you remember, the scleral zone, or sorry, the central zone and the limbal zone, we can manipulate 300 microns. In the scleral zone, we can only do it 200 microns. But again, if I can go 200 microns in one meridian and 200 in the other meridian, that's 400 microns of toricity. So plenty. We can do it in a quadrant specific manner, noting where that lens has rotated and what quadrant you need to make that change in, then we can do that. So I can make it 360 degrees, I can make it in a meridian, and I can make it in one quadrant. So I did see question with the prolapse. So again, there's not really one right answer for the cons prolapse. It's sort of trying one thing first and seeing if that solves the problem, because you can flatten your limbal area again to push some of that tissue back down if it is coming under. You can steepen that limbal area to leave more room for that tissue that's coming underneath. Sometimes it's coming out over the edge. And if it is coming out over that edge, then you need to flatten the edge to relieve some of that pressure because it's diving in and it's too steep. So there's not one right answer. All of the solutions, though, are in the fitting guide, and it gives you those options in there. So you can be assured that looking at the fitting guide, if you have that issue, and going through those steps will help. All right. Just some visuals of what you may see at the edge. I'm sure you're all aware of this. One thing I would caution is sometimes we try to tweak, meaning make small changes just because we see a little bit of a problem at one area. You know, if we saw a couple of vessels disrupted at 9 o'clock, we want to make a change. You know, you can have a really well-fit lens that a patient's getting best corrected visual acuity and wearing it the whole day, and you're not causing any issues. I don't have to make that change if it is just a small area that we're dealing with. All right. Decision tree, again, all talking the same language, do your evaluation and then make the change accordingly. Again, all of these things, I want to leave some time. All of these things are in the fitting set. So if we're seeing a tight edge, what are we seeing and what change do we make? All in there with those. If we're seeing a loose edge, again, you can go through all of these and look at those. We talked about some of that tear cloud and why it may be coming. It could be from too much central clearance. It could be from too much limbal clearance. It's another situation where you kind of have to search and destroy. It could just be the makeup of the patient that they're going to get that buildup behind the lens. Some patients just have to remove that lens and replace the saline halfway through the day because they just get that buildup there. You may have a perfectly fit lens and still have that problem. Okay. We talked a little bit about front surface torics. You know, it's easy. Just use LARS, just like a soft lens, and what that rotation is, noting your dots and how much rotation, then they can offset that over refraction with that cylinder and that axis. So important to make that note. As of now, we only do notching. We will have microvolts in the future, in the near future. We're working on many different things to enhance the design, which we consistently do. And that's a big part of my job. But right now we do notching. If you've had to do this, it's pretty simple. We get the lens fit first, and then we can go back and look at that notching and see how much we have to take that notch in from the edge and then how long. We are not doing fenestrations as of now, Najee, but that is another thing that will be part of the enhancements that are coming in the next year. Another important thing, and I don't know how much has been used there, but I'm sure in your area, again, going back to climate, the tangible hydrogen peg is a great problem solver for these patients that are dry eye. We have all that hydration behind the lens, but the front of the lens can still be a very arid, dry area. So that tangible HydroPeg can help with that. It's for heavy depositors also. If you have any problems with that, I would highly encourage you to use the tangible HydroPeg. This just creates a super slick surface. It's a bonding liquid or agent that bonds to the lens and creates a super slick surface. They use this polyethylene glycol in different forms on pills to slide down the throat or on boats to go faster in the water. So an MD created this formulation to bond to a contact lens for that very reason, to resist deposits and help create a comfortable area, especially with those dry eye patients. So we left some time for questions. I know we've had a few and we can address those. Do we have any? Okay, so now the problem is that when the sclerolone is lifting, you have excessive movement and often decentration. Yeah, I would agree with that. So Najee, if you could put it in your in this is your expertise, why the fenestrations, what does that help you with? Oxygen. Yeah. So yeah, we're dealing a lot of times with these corneas. So we think about the thickness of the lens, the tear and saline layer. By the time we have oxygen through that lens, and then through that, it can be deteriorated. So that fenestration can help with it if you're having hypoxia or anything like that. That fenestration can help it. It's tricky sometimes with fenestrations just because you can't create air bubbles under there. You are getting more debris and things behind the lens sometimes. So it is tricky. So for the HydroPeg, they're saying it's a year, but it all depends on the cleaners and the patient and how they treat the lenses. What we're seeing mostly is about 6 months that it will last with the HydroPeg. And it is only compatible with 4 different care systems. So Unique pH, their own care system, Clear Care, and what's Simplus. I think that's right, Felipe? Okay. I'm going to go back and see. I think we answered the prolapse. Low cell count, yep. Other questions?
Háblate con Byron. Sorry, Tony. I just got on a phone call from a customer in Ecuador. I'm here. I'm sorry. Apologize.
You're good. We were just addressing some questions. We talked about HydroPeg, and I think the 4 compatible solutions are Simplus, Unique pH, Clear Care, and then their own solution, correct?
Correct. And there's another solution available in the Middle East. It's called OTE, OTE, and they are based in the Netherlands, and it's also compatible with HydroPeg. In fact, they're the ones who designed and developed the HydroPeg booster for HydroPeg. They're located in Netherlands. So if anyone has questions about it, just send me an email, and I can direct them to OTE.
Good.
Okay, go ahead.
Other questions?
Dr. Subo had a question, and I'm going to open his microphone to him So give me just 1 second. Dr. Subo, I'm going to promote you as a panelist. Once I do that, you can talk and you can share your screen so you can share your case, okay? Go ahead, Dr. Subo.
Do I have to,
No, no,
do
no,
I
no.
have to
You don't have to do anything. Dr. Subo, you can share your screen if you want, or you can share your case through the microphone.
Yes, Felipe, how are you?
hello, doctor.
Yeah, how are you, doctor? Good evening.
Good.
Yeah, I had a case, but a fitting with the patient, but I don't know how to share my screen, Felipe. Yeah,
I think at the
so
bottom where it says more, and then if you click on more, you go up to share. It's at the top after you.
no, there is only caption and disconnect audio only. I have to show you the picture because it was one of the challenging cases that I had.
Okay. I think Felipe has to share it. He may have to give you the authority.
Yeah, I believe that.
And what type of case is it?
It was a postgraph.
Okay.
And I did the fitting using the old design.
Mm-hmm.
I used E-lens with the
E.
SAG 4754.
Okay.
It was when using the fluorescein from the whole cornea, it was good, but only a specific area there was a touch.
And that was in the central area?
No, it was it's on let's say 11 o'clock.
Okay.
Yeah, only that area it was touching, but the full pattern of the fluorescein, it was good actually. So what can we do in that case?
So in this case, from the old set, the consultant will have to put that lens into the new design, not new design, but into the new parameters. So we can break that lens down, and that's where you can control it by that area. If you had just that touch at 11 o'clock, then we can make that change just in that area. Now you're saying, is that in the limbo area or the edge?
It's in the limbal area.
Okay. So yeah, if I had
limbal to central.
Okay.
Actually.
And again, we can make the change in that entire limbal zone, which would probably make it easier because we don't have a toric edge where that lens can lock. So I would I would just make the change 360 degrees because we can't make that lens stay in that position without a toric edge, right? If we have a spherical edge, it may move one way, it may move the other way without that lens locking into place. So I would just make it in the entire limbal zone, depending on how much you need to lift that. Does that make sense?
The problem that I have to show the picture so that you can get the whole image of that one. So if I increase the SAG 360, you mean?
Yes.
I believe it will. Yeah, it will be the SAG will be too much, knowing that it's post-graft, so it will affect the oxygenation.
then yeah. We would have to know that that lens is, we can get it to stay where it is. Because again, if I make it to just that one area, I have to make sure that that lens will move back to that area. It's a
Yes, yes,
15-0
I understand.
Najee. Yeah. Yeah. That is the other option, is to put the 16.5 on there.
Okay.
Yeah.
Also, that's
But if you've already fit the patient,
yeah.
we can make.
I didn't really order that one because it was very challenging, and I was afraid to do anything, and it will not solve that problem.
Yeah, that's because that's why we didn't, back then we didn't offer quadrant specific, because you have to have that lens where I know that it's rotated. So if I rotate it out of place, it either goes back into place or it stays where I rotated it, and then I can make those changes. But that's a great suggestion by Najee, is just try a larger lens.
Okay, thank you, doctor. Thank you very much.
You're welcome. More questions? That was a good one. And it is a hard transition sometimes from that older generation set to the new set, because of that very reason. We learned a lot from that.
Actually, doctor, mostly I still using that older design. It was really good, because we only here in our region, mainly we are using only CD and E. Let's say 95% of our patients on these three lenses.
Yep. And that's the way it was, years back. And where you'll find out is in this same thing, in this case, those really highly challenged corneas is where you're going to need more of that manipulation. And again, a larger diameter and the toric edge.
Or a quadra specific changes, yes.
So the other suggestion could be this, doctor, is we order a toric edge for that lens, and then we can evaluate that and make sure that lens is in place and make the change in the right area. So we can just add some toricity. So if you go back to, we said with the 15.5 diameter, we did 150 microns of toricity. So if you have a 15.0 on, we would do 100 microns. So we could order that lens, the 15.0 with 2 steps flat, 2 steps steep, right? And make a toric edge. And then you can evaluate where you see that limbal touch, and we can make that change in a quadrant specific manner. That's the other option.
Yes, I understand that.
Okay, good.
Thank you.
You're welcome. Okay. Felipe, you there? Any other questions? Okay, he must be busy. Thank you for your time. If you need to contact me, Felipe has my information. And if we need to do follow-up or anything else, just please let me know. I appreciate your time.
And this is going to be the first one of many. We are going to do one in Arabic as well. And again, if you want us to do workshops, hands-on training, if you want to visit clinics with us, let us know. We have a very robust plan for the Middle East in 2026. So I'm always here. We have a team of 4 consultants. They're all optometrists. So keep your questions coming. And I want to thank Excel Contacts and Tony Caporali for his time. Thank you so much. Are there any other questions? No? Okay. Thank you so much, T. You take care.
You.
Looking forward to seeing you. The session will be the session was recorded, and I will share the recording session with each one of you.
Okay,
Thank you, doctors.
thank you.
Take care. Bye-bye.